Welcome back to the deep dive. Today, we are getting to something really personal, a topic that, it affects almost everyone at some point. The marks left on our faces. We're talking scars, texture, discoloration, all of it. Our sources for this, a lot of comprehensive clinical reports, they all point to this one fundamental truth. The face is just so central to our identity. It's how we engage with the world.
It really is.
So when changes happen, from bad acne and injury, whatever, the psychological weight can be, well, enormous. Our mission today is to give you the clinical shortcut. How do these marks form? And more importantly, what actually works to fix them based on evidence?
That's the key, the evidence. We're going to unpack the etiology, that's just the fancy term for the causes, and then get into the therapeutic interventions that dermatologists actually rely on.
Okay.
But before we get all technical, there's this initial aha moment that you really need to grasp, and it's the answer to the question, why do we scar in the first place?
Right. Why doesn't it just heal perfectly?
No, because the body, in a moment of crisis, is a survival machine. Its absolute number one priority is rapid closure and preventing infection. It doesn't care about aesthetics.
Just plugging a hole.
It is throwing down scaffolding as fast as it can to seal the wound. And sometimes that scaffolding, the scar, it's just messy.
That reframes everything, really. It's not a failure, it's the body doing its primary job successfully. Okay, so let's unpack this. It all starts with the skin structure itself. Can you give us a quick refresh on the 3 layers where all this happens?
Of course. So you've got 3 main layers stacked. The outermost one is the epidermis. That's your thin protective barrier. And it's vital because that's where the melanocytes live, the cells that make pigment.
And if you just scratch the epidermis, you're usually fine, no scar.
Usually, yes. But beneath that, you have the dermis. This is the real engine room. It's packed with collagen and elastin. It's the structure, the strength, the texture of your skin is decided here.
Okay.
And then deep below that, you've got the hypodermis, which is basically the fat layer for cushioning.
So if a minor scratch on the epidermis is fine, what's the dividing line for a true scar?
A scar happens when the injury is deep enough to break through that barrier and hit the dermis. Once you damage the collagen factory, the normal, tidy regeneration process gets thrown out the window.
And the emergency repair crew takes over.
The emergency crew takes over, exactly.
So walk us through those 4 stages of wound healing from the sources. They're so crucial for understanding why a scar looks the way it does 6 months down the line.
Right, so the first 2 phases are almost instant. Phase 1 is hemostasis,
The bleeding stop.
immediate clotting, the body pulling the emergency brake. Then right away, phase 2, inflammation. Your immune system rushes in, sends white blood cells to clean up all the debris, fight off bacteria, and this phase also unleashes a flood of growth factors. It's a system-wide alarm that major construction is needed.
And then comes the actual construction phase.
Phase 3, proliferation. This is the building phase. Specialized cells, they're called fibroblasts. They just swarm the area and start laying down a new matrix. But they're using a temporary, kind of disorganized collagen, type 3 collagen, to fill that hole as fast as possible.
Like temporary scaffolding.
The perfect analogy. They're prioritizing speed over quality at this point.
Which brings us to the final stage. The one that I think frustrates people the most because it just takes forever.
That's the remodeling or maturation phase, and it is slow. It can last well over a year, sometimes even longer. During this whole time, the body is slowly breaking down that messy type 3 scaffolding and replacing it with a stronger, more organized type I collagen. But, and this is the key, it's laid down in this sort of dense parallel fashion, not like the original basket weave pattern of healthy skin.
And that different pattern is why the final scar is biologically distinct.
Yeah, that's it, precisely. The finished scar looks and feels different. It often lacks a good blood supply, and critically, it's missing all the original hardware. No hair follicles, no sweat glands, and often a totally different pigment or texture. It's functional, but it's a rush job.
Okay, now that we know the process, let's classify the results. Looking at facial scarring, it seems like we group them by whether we lost tissue or gained too much. Let's start with the depressed ones.
Those are the atrophic scars. They're sunken, they're below the skin surface, usually from something that destroyed the underlying collagen, like severe acne or chickenpox.
And the sources say identifying the specific type is everything for treatment.
It's critical. You generally see 3 main architectural types. First, you've got ice pick scars.
They look just like their name.
They do. They're deep, very narrow, almost like tiny punctures that go way down into the dermis. Then you have boxcar scars. These are broader depressions, but they have these really sharp, defined vertical edges, like little craters.
And then the third one, the one that gives the skin that That wavy, uneven texture.
Those would be rolling scars. They're wide, they're shallow, but unlike box scars, their edges are sloped and soft. It creates this undulating appearance, and they're often they're tethered down by these little fibrous bands underneath.
That covers a loss. Okay, so what about the opposite? The raised scars, where the body just made way too much collagen.
This is where the distinction between hypertrophic and keloid is probably the single most important classification in all of scarring.
Why is this so important?
Because they behave so differently. A hypertrophic scar is raised, it can be red, maybe itchy, but it strictly stays within the boundaries of the original injury.
It respects the border.
It respects the border, and it can often improve on its own over time. Keloid scars, on the other hand, they're a different beast. They grow aggressively beyond the original wound's borders. They invade healthy skin.
Wow.
They can show up years later and just keep expanding. They honestly behave more like benign tumors of connective tissue.
Oh.
And there's a huge genetic component. They're much more common in darker skin tones, and they almost never go away on their own.
That's a really heavy diagnosis.
Yeah.
If they're that aggressive, how do you even approach treating them? You can't just cut them out, right?
You can't. If you do, they'll likely grow back even bigger. So the mindset shifts from excision to suppression. We treat it like a chronic condition. The goal is aggressive anti-inflammation, usually with injections, which we'll get to.
Got it. And what was the third, the less common scar type?
Contracture scars. You usually see these after a Meiji burn. The skin tightens up so much that it can actually restrict movement, especially around the mouth or the eyes.
Okay, so that's texture. Let's switch gears to tone. Discoloration or dyschromia. This is where it gets really interesting, I think, because the whole mechanism changes. We're not talking about collagen anymore.
Right, now we're talking about melanocytes producing pigment. And the most common form of darkening we see is post-inflammatory hyperpigmentation, PIH.
Which can come from almost anything, right? A pimple, a scratch.
Anything, acne, eczema, a bug bite, even a cosmetic procedure. Any inflammation can kick the melanocytes into overdrive and they just start pumping out excess melanin.
And the sources make a really critical distinction here about where that pigment ends up.
Yes, and it dictates how hard it is to treat. If the extra melanin is just deposited in the top layer, the epidermis, we call that epidermal PIH, it looks tan or brown, and it's pretty treatable because you can shed those surface cells.
But then there's the other kind, the really stubborn stuff that looks almost gray.
That's dermal PIH. What happens there is the inflammation is so bad, it ruptures the bottom layer of the epidermis, and the melanin literally falls down deep into the dermis.
Oh, wow.
And once it's down there, it gets gobbled up by immune cells, and light reflects off it differently. That's why it looks bluish gray or slate gray. And because it's so deep, topical treatments really struggle to reach it.
That explains so much. It's literally buried. Okay, but what about beyond PIH? The sources talk a lot about melasma.
Melasma is a big one. It's a chronic condition. You see these symmetric, blotchy, brown to gray patches, usually on the cheeks, forehead, upper lip.
And this one is really tied to internal factors.
Hugely. It's driven by hormones, so pregnancy, birth control pills, plus genetics, and critically, UV exposure. They call it the mask of pregnancy sometimes. And it's a constant battle to manage because you're fighting your own biology.
Then you have what everyone just calls sunspots or age spots.
Right. The clinical term is solar lentigens. These are flat, well-defined brown or black spots from years and years of cumulative sun exposure. It's basically an area where the melanocytes have started to multiply because of chronic UV damage.
And finally, let's touch on redness. Sometimes the lingering mark isn't brown, it's just persistently red.
That's either erythema or telangiectasias. Erythema is just generalized redness from dilated capillaries, common after inflammation, or in rosacea. Telangiectasias are what people call broken capillaries. They're those visible, fine red lines that are permanently dilated. Need a completely different tool set to treat red versus brown.
Okay, we have thoroughly covered the what and the why.
Yeah.
Now for the most important part.
Yeah.
What do you do about it? The sources are crystal clear on the one foundational step that makes or breaks everything else.
If you take away just one thing from this entire discussion, let it be this. Daily, year-round use of a broad-spectrum sunscreen, SPF 30 or higher. It is non-negotiable.
Why is it so fundamental? I mean, more than any fancy cream or laser.
Because UV exposure is the great accelerator. It undoes all your progress. It makes fresh scars darken. It triggers melasma. It stimulates every pigment pathway you're trying to shut down. If you're spending money on treatments but skipping sunscreen, you are actively fighting yourself.
It's preventative and supportive all at once.
Exactly.
Understood. That's the baseline. So with that in place, let's get into the specifics of topical agents for discoloration, the depigmenting agents.
The gold standard for a long time has been hydroquinone, usually in 2% to 4% concentrations. It's powerful because it directly inhibits the enzyme tyrosinase, which is the key enzyme for making melanin. It basically shuts down the pigment factory.
But there's a lot of caution around it. If it's the gold standard, why isn't it the only thing people use?
That's a great question. It's powerful, but it needs medical supervision. Prolonged continuous use can cause this rebound condition called ochronosis, which is an irreversible blue-black discoloration. So you have to cycle it, you use it for a few months, then you take a break.
Okay, so you need other players for the off cycle, or for people who can't use it.
Precisely. And that's where retinoids come in. Things like tretinoin. They're fantastic because they do two things. They speed up cell turnover to help you shed the pigmented cells, and they also stimulate new collagen. So they help with both tone and texture.
Right, a double-duty agent. What about some of the gentler options for long-term use?
Two big ones are azelaic acid, which is great for acne and PIH because it calms down abnormal melanocytes. And the other one that's everywhere now is niacinamide, or vitamin B3. It doesn't stop melanin production, but it blocks the transfer of that pigment into your skin cells. It's like a gatekeeper.
Okay, and before we hit the big procedures, what's the evidence-based first step for the raised scars, the hypertrophic and keloid ones?
Silicone gel sheets or gels. The research on this is really solid. They work by hydrating the scar and trapping that moisture, which helps regulate the fibroblast activity and calms down collagen production. It helps flatten and soften the scar. It's cheap, it's effective, and it's where you should always start.
Now we get to the advanced tools, professional procedures. When you need serious remodeling, doctors turn to lasers. Let's start with the heavy hitters, the ablative lasers.
Ablative lasers, like CO2 or erbium, are revolutionary. They literally vaporize the top layers of the damaged skin in a very controlled way. This forces the most powerful healing response possible, leading to incredible collagen remodeling.
That sounds intense. So what's the trade-off? The downtime must be huge.
The trade-off is significant, yes. You get massive results, especially for severe scarring, but you're looking at weeks of downtime, real downtime. And there are risks, prolonged redness, infection, and ironically, if aftercare isn't perfect, you can actually cause more hyperpigmentation.
So for people who can't do that, there's the fractional approach.
Exactly. Non-ablative fractional lasers, like Fraxel, are the workhorse for a lot of dermatologists. Instead of vaporizing the whole surface, they create these microscopic columns of heat deep in the dermis.
So it leaves healthy skin in between.
It leaves the surrounding tissue completely intact, which means you heal so much faster, way less downtime. It's excellent for most atrophic acne scars.
And then there are lasers that just target color, right?
Yes. For brown spots, like sunspots and PIH, we use pigment targeting lasers. Pico or Q-switched lasers, they use these ultra-short pulses of light to just shatter the melanin particles. The body's immune system then cleans up the dust.
And for the red marks?
For red, you need a vascular laser. The gold standard is the pulsed dye laser, or PDL. It specifically targets the red in your blood, the oxyhemoglobin. So it's essential for zapping those broken capillaries and calming down redness from rosacea or new scars.
Okay, that covers light therapy. What about physical resurfacing? Microneedling is everywhere.
Microneedling or collagen induction therapy, it works. It creates thousands of tiny, controlled micro-injuries with sterile needles. This mechanical damage kicks off that whole healing cascade we talked about earlier, forcing the skin to produce new, healthy collagen to repair itself.
And let's clarify something that gets confused with it. Subcision. That's a very specific technique for a specific scar type.
It is. Subcision is a brilliant procedure for those rolling scars we mentioned, the ones that are tethered down. A dermatologist inserts a special needle under the skin and literally cuts those fibrous bands that are pulling the scar down.
But cutting the band doesn't just make the scar pop up, does it?
Not instantly. Releasing the tension is step one. But step 2 is that the small pocket created by the procedure fills with a little blood, and that controlled wound then heals by creating a new pillow of collagen right underneath the scar, lifting it up from below.
That's fascinating. Okay, let's wrap up with the main injectable treatments.
For the raised, aggressive keloids and hypertrophic scars, the primary treatment is corticosteroid injections, usually triamcinolone. It's injected directly into the scar to act as a powerful anti-inflammatory, shutting down the overactive fibroblasts and convincing the scar to flatten.
And for the opposite problem, the depressed scars.
We can use soft tissue fillers. Injecting something like hyaluronic acid directly underneath an atrophic scar gives you immediate volume. It just lifts the depression right up to the level of the surrounding skin.
But that's temporary.
It is temporary, yeah, maybe 6 months to 2 years, but it gives an immediate aesthetic improvement, and sometimes that gentle stretch can encourage a bit of its own long-term collagen growth.
What a fantastic overview of the whole toolbox. So, to summarize, the real key takeaway here is that success demands a multimodal approach. You have to correctly identify the problem. Is it a tethered rolling scar or deep dermal PIH? And then combine that non-negotiable foundational skincare, especially sun protection, with a tailored professional treatment.
Absolutely. The first step has to be a consultation with a board-certified professional for an accurate diagnosis. You have to know what you're fighting, because the treatment for a boxcar scar could make melasma much, much worse.
And here's a final thought to leave you with, building on the biology we talked about. What's so fascinating is how the body's simple, innate priority for survival, that rapid, messy healing, can lead to this huge spectrum of complex and persistent aesthetic challenges. It's just a powerful reminder that nature is ruthlessly efficient, but it's not always an artist. It leaves the finishing work to us and our dermatologists.
It does, and thankfully, the therapeutic landscape is always evolving, always getting better. Thank you for diving deep with us on this.